In 1989, the physician's proposal was published in the New England Journal, and then in 2003 in the JAMA. And the 2003 publication was maybe the most successful organization building activity that PNHP had done. And it seemed to me that with the passage of Obamacare and the recoil or the falling back that many of our liberal friends had, you know, the feeling that maybe something that was supposed to be good wasn't so good, that a restatement of the physician's proposal would be a good way to advance the cause and build support within the physician community. Publishing at this time turned out to be a lot harder than it used to be. Many of us have been appalled at the New England Journal's pharmaceutical-friendly neoliberal editorial policies these days. For example, I think that, I don't know the details about the negotiations with the AMA journals, but I know that there were some. And it ended up being published in the American Journal of Public Health, which I think is fine. You know, it's a peer-reviewed journal. What else do you need? So my view of this proposal is something that we should be using to win our colleagues to the ideas that we have. Maybe not in every letter of the actual proposal, because it went through an editing process which brings it down from thousands of words to a few thousand words, almost down to hundreds of words. But in terms of the ideas, we should have something that we can win our colleagues to, and I think this gives us a fresh opportunity to do that. So there's a few thoughts. Maybe now we could have a dialogue.
I was wondering how the group arrived at the decision not to promise any initial savings.
You know, I don't know the details of that. I think that the boast that there'd be $400 billion in savings is something that's been a flashpoint for many of the critics of the plan, you know, over the time. I think the idea is more that everyone would get access immediately. And if you had $400 billion, which has got to be a low numbers, by the way, then there would be plenty of money to reinvest in the care of those that don't have it now. So I think that's the thinking behind that. I actually don't know the precise answer. One of the things that always occurred to me about PNHP's boasts about savings and weeding out corruption is that we really have no idea how much outrageous perfidy, is that the word? How much, you know, how much awful gamesmanship is played. And if you had a hospital on a global budget, all of a sudden, how much waste would be exposed by opening to the public where the money all is. Or if you had, let's say a dialysis center, you know, on a public budget where it needed to be funded the next year, and it was all public, and every penny could be accounted for, how much waste would be exposed. I mean, there's enormous amounts of gaming the system in every way. So how much savings there is a little bit of up to our imaginations to explain to our recruits, I think, not so much a policy question. The one thing that happens, though, in terms of the science of how to describe the economics of it all, is I think PNHP has evolved a method of never risking its reputation on a boast and always trying to stay within very narrow evidence that this has been shown somewhere. And so we don't really say, oh my God, there's so much waste. It's unimaginable how much true waste there is when every player in the game is trying to make a profit. What we instead say is, well, if you compare it to Canada and it's apples to apples, then there might be $400 or $500 billion easily, right? Is that useful answer? I don't know.
On that line, I noticed that Jerry Friedman wasn't quoted in any of the references.
Yeah, so Jerry Friedman's a good example. I think that how things would be in the future depends on the class struggle, forgive me, but if there was a workers and farmers government and the finance capital people were completely cut out, we would have a very different picture of how much healthcare would cost than if there was a friendly liberal government that had some inroads into the neoliberal system, but not completely. I think the way I look at it is in that way. I can't predict how much power our side would have if this reform started to be enacted, right? And so it gets quite beyond science because it really has to do with political power. If there was enormous popular political power, there would be the opportunity to say to the pharmaceutical industry, you don't exist, right? This is a public good. Pharmaceuticals are a public good. And in modern society, no one can make them in their backyard. It's not a question of libertarian individualism because it's a social enterprise to make scientific pharmaceutical products that can really help human beings, and therefore it should be a public good. So it shouldn't be a business. It should be a good thing for all. We're going to only use the best. We're going to say that proton pump inhibitors are incredibly useful. If you have a bleeding ulcer, you should have the best proton pump inhibitor. We don't know if omeprazole or pantoprazole are better. So therefore, we're going to do a head-to-head comparison. Oh, it turns out that one is better than the other, and that's the only one we're going to make, Or one is better than another for those with this genetic makeup, and for those with a different genetic makeup, we're going to give the other one. We're going to do it in a specific scientific way, and we're going to be in charge of all that, and we're going to count ourselves only on science, not on profits. I mean, we don't even think that way. We don't think that that kind of popular power is possible. But obviously, if healthcare for all is our dream, then we might think that way a little bit. But we wouldn't be wise in the contemporary debate to base our policies upon things that are wishes and not actual facts somewhere. So I think that that's the method. It's to try to stay within science as best we can based upon what works somewhere else right now.
I think, though, that the involvement of young people in the Sanders campaign is evidence that people have that they are expressing their values for universal care and for a humane health system. And so then the question is, how can PNHP advance through its usual ways of working? How can it advance the discussion of values, which you were just talking about, and one of the values being that, that no company should be profiting from a system that allows so many people to be neglected or forced into greater misery. So, I guess I'm just trying to figure out how the values part of this discussion could be pushed.
Well, I'm way in favor of just continuing to try to do exactly that. The Sanders campaign, I'm not a very vigorous Bernie Sanders person personally. Maybe I should be. My son is. PNHP, of course, is an educational institution that gets a tax place by not lobbying and can't support candidates. But I think if you put it a little bit objectively, Sanders has proven that running on an anti-corporate, anti-capitalist platform on ideas alone, I don't think it's his hair, I don't think it's his incredible reality TV presence. It's Bernie Sanders is running on his ideas, and it's humbling to think that that campaign has had the success that it has among the young people. I think that we have a special obligation to try to reach out and be confident that this kind of profound change is possible. And I think that in American medicine, we're trying to set an example seldom set, and we should kind of be serious about how much responsibility that brings. A lot of the times it's very tempting, I think, in terms of the practicality of the single-payer proposal to think about, well, they could do this tomorrow. Why don't we make them do it by a smart argument? But really it has to do with enormous historic forces and who has a lot of power. And to stick in there and be in favor of physicians or caregivers broadly, meaning from family members to nurses to physicians to support staff of all types in all kinds of situations, helping other people who happen to be ill or people who are trying to become healthy. Think about that huge social goal. I think we should really embrace the importance of that, and I think it will find a response. It's kind of the amazing thing about what we do is, and within the demand for PNHP, which is that if we take an initiative these days, it continues to get some kind of response. It's not a falling on deaf ears at all, and there's a lot of room to go forward. I was astonished yesterday. I met an old friend that who's not political at all, and the person he said that he couldn't understand why healthcare wasn't the only thing the country was talking about because of his experiences with his children and his parents, and it was all personal. It wasn't. And I think that that's where we're at. I think that when it comes to the needs of caregiving in terms of modern medical surgical needs, everybody has someone in their immediate family who's been in some ridiculous, undignified situation. And often I think that we should, we can make a smart policy proposal about what would actually work, but often I think that a moral appeal about the need for a dignified caregiving system is really all we need, because I think that's not lost on anyone much these days. And practicing in the hospital, I can't think of a patient for whom some crazy money thing or he needed to make an appointment for his son and they wouldn't answer the phone. And isn't that outrageous? And I said, it's kind of funny. I have a patient with a broken nose and I can't get the surgeon to answer the phone because she has to have her nose fixed within the week. And I'm spending an hour trying to get my patient seen by my colleague who knows why I'm calling. That's how broken the system is. And it's kind of funny to be explaining it to your brother who thinks it's silly because he can't get an appointment when you're in the system and you can't get an appointment, So I think the dignity question is enormous, and I don't think it's lost on many of us. So I think there's a lot of room. There's a fertile field to plow.
The pharmaceutical industry is global, and so it deals with all these other nations that have various forms of national health insurance, as well as the United States. Sitting here in the United States, we tend to think of ourselves as bigger than all of them. but we aren't. So the pharmaceutical industry is having to deal with negotiating with national systems already. How effective are they, and how is this going to, how does this impact our idea of what we could do vis-a-vis making the pharmaceutical industry serve humanity instead of just its shareholders?
Well, I kind of picked the pharmaceutical industry deliberately because it's not something that we have been aiming to take on directly. Our friends in the Canadian Doctors for Medicare had a whole project about what if they had pharmacare for Canada, which would be free pharmaceuticals. They did a study. They based the savings upon New Zealand. They came up with unbelievable savings to the system if the Canadian system had the same kind of pharmacare that New Zealand has. It's a very, very specific demand. It's a lot like the methods of PNHP. So Canada does not even have pharmacare. Our friends in Europe will tell us that, when it comes to bargaining with the big pharmaceutical companies that are based in Europe, that there's only so far they can go. You wouldn't dare talk about nationalization. So your point is well taken, that these are enormously powerful corporations that we can only dream about making public. But on the other hand, I think just raising the question is what we're obligated to do. And single payer would be an oblique threat to the pharmaceutical industry because it would raise the specter, if you will, of bargaining with them for prices, which is outlawed in the United States, except in the VA system. And, I think it's an oblique threat to the pharmaceutical industry, not a direct threat. And maybe you're right. It would take a global decision to make the science of pharma into a public good. Is that an answer?
Yes, I think that's helpful. And by the way, I think Justin Trudeau, the current Prime Minister of Canada, one of his platforms that got him elected was the idea of putting in pharmacare in Canada. I think he has promised to do that, although I haven't heard anything. The silence has been deafening since he's been elected.
You mentioned before something we all know, that everybody knows folks who've been screwed over one way or another. I mean, Michael Moore made a great movie about it. But along those lines of playing on the values, playing on what people can relate to, given what they know and what they've experienced, does PNHP entertain any kind of public relations effort? Having people tell their stories. How do you get that message across? I mean, we always have these stories out in the newspaper, everybody has a bake sale because someone has cancer and all of that stuff. But is there any thought of trying to do this on a national scale just to raise that awareness, however you might do that?
So the question of explaining the system, PNHP definitely has a national public relations presence. And, I think that the success of the rollout of this proposal, the media success which continues. I mean, I think what was the most recent couple of things? Marsha Angel in the Boston Globe, and Karen Palmer in the Toronto Star. And I think Karen Palmer's Canadian piece about why American doctors want Canadian-style Medicare has gotten legs. Anyway, PNHP has some media expertise and some savvy, and Mark Almberg is enormously responsible for that. On the other hand, the organization of PNHP is quite unique as an institution in that it's simply the sum of the collective efforts of its membership. So that whatever we do for PNHP, whether that's advertise our neighbors or friends or patients or colleagues' stories, or whether we further that, you know, that's kind of on us. And I would add that, you know, California Nurses Association had tried a patient stories effort. They actually made, I thought, very good success for a while. But PNHP is not the kind of organization where we decide to tell our staff to go on and do a project. It's more an organization where we expect our member doctors and members who are not physicians for that matter, but we expect our membership to use their own creativity to advance the cause, and then the national organization is there with a modest apparatus to support that effort. So if we had an idea, if you had an idea, if I had an idea of locally something that's compelling that PNHP could help tell the story of, then that would be the organizational model. And I think that in terms of our impact, that this organizational model turns out to be superior to the alternative. Longtime member of PSR, myself, and PSR has a pure mission, you know, especially around the abolition of nuclear weapons and hopefully nuclear power. And also had some mission creep and some other great proposals, working on gun violence and working on environmental toxins, for example. But telling the staff what to do in your name is a very different idea. I'm just saying that because I know PSR a little bit. And I think that the best of PSR are the doctor advocates and activists, you know, who go out and do the work of the organization, not the staff who do it in your name. So PNHP has always had that idea that we should be an organization of activists, and our work product should be our collective work product, whatever that means. And our national office is there to support us. So when it comes to telling the stories of sort of the indicting the system, if you will, we definitely have a method in terms of health policy evidence that the system fails people, that there are hideous disparities, unbelievable injustices, lots of people left out. The anecdotes that support that, I think, are up to us to figure out how to tell in our own communities. And thinking about it, I actually do think that this organizational model is superior because it encourages us to work where we're going to be most effective, which is in our own front yard. So yes. So the answer is yes, we should do that. And yes, we should do that in a personal way.
Yes, I wondered if you could comment on the Colorado Care Initiative. Now, I haven't gone into the details of it myself, but I'm pretty concerned about using the initiative method because to me that's playing on the enemy's turf where they more or less control the media. And similar single-payer initiatives in Oregon and California got royally creamed. And I wonder why Colorado went that direction.
Well, the Colorado proposal, of course, is not quite a single-payer proposal in its details. There's a lot of ironies and contradictions in the state-based approach that are quite challenging, I think, to conceptualize. And, you know, Vermont, for example, small state, 750,000 people, the best educated and single-payer probably in the whole country. Maybe because of a PNHP person, Deb Richter, all by herself, just from more than 10 years of dogged efforts at the grassroots. And then little by little, the tipping point comes where it becomes very, very popular, and the Democratic Party governor runs on single payer, making a deal with the third party. Of course, Vermont's peculiar, right? It has a progressive party. Thanks to Bernie Sanders' early career, although he's not in the Progressive Party. The whole Progressive Party is thanks to his efforts in Burlington. And the Progressive Party doesn't run against the Democrat because the Democrat stands for single payer, and then he pushes it along up until he says that, oh, it would cost too much money, and retreats, On the one hand, at the state level, there's enormous grassroots work that can be very, very, very successful in terms of educating people about what it would mean for everyone in the society to have equal access to necessary care. That's amazing at the state level. On the other hand, there are a lot of devils in the details. If you wanted to make it happen on a state level, what about the fact that the whole system continues to exist outside the state, and there would be relentless attacks from the powers that be, the pharmaceutical, the insurance companies. I almost said pharmaceuticals because I'm still thinking about that, but the insurance companies that didn't control your state. And in Vermont, there was a good example where, IBM is a national company and they employ a lot of people, and they wouldn't want their employees to be part of your plan, so you'll make an exemption for them, obviously, and that kind of thing. Here in New York, there's the same thing. In Colorado, I don't think the proposal is a full-on single-payer proposal, but yet it adds to the currency of the idea. So how do we figure all that out? I think we should say single-payer is a good idea. We should make it work. And we should make it, in order to make it work for one state, we might have to make it work for all the states. That's my opinion. Some people would like to see an experiment go forward, but kind of feel like, personally, I feel like it's the big powers that be giving us the permission to go forward. So does it discredit us to have someone in Vermont or Colorado or New York say that, or Pennsylvania or California or anywhere, say that, that this is the only thing that's practical when we don't think it is? I don't think it does. I think we just have to say, well, I'm not sure I agree with you that it's practical, but I would like to agree with you that single payer is the way to go. Let's talk about what single payer is. And the more you talk about what it is, the more it really means everybody in, nobody out. And the emphasis should be on everybody.
The Washington Health Security Trust, which is a bill that's been languishing in our legislature, that would do essentially the same thing in Washington State if we ever got it taken seriously. I think the most important thing positive about both issues is that both of them, if passed, would end uninsurance. Everybody would indeed be covered, because the people who would be excluded are the people who already have coverage through federally protected programs of one sort or another, primarily Medicare, Medicaid, the veterans, the military, Indian Health Services, and the like. So that's an important thing. If Colorado Care, yes, passes, it will cover everybody in Colorado who isn't already covered under a federally protected program, and nobody will be uninsured. So it is everybody in, nobody out. And I believe Colorado also would cover the undocumented. I know Washington State's plan would cover the undocumented as well, so that everybody, it would be everybody covered. So let's not lose sight of that. While it's true that because of the existence of federal law that states can't mess with, no state can pass a truly single-payer system.
I was thinking more in terms of strategy. It seems that every time we've tried the initiative process, this has been a devastating failure. So why did they try the initiative process?
I don't have any comment on why an activist in Colorado would try one tactic or another. I think I would trust them to do the best thing that they could do. The question, however, about the least increment, we all sort of live with this idea of incremental reform and what's the best, and increment that would get us closer. I think Physicians for a National Health Program, the least increment that we're supposed to be in favor of is a national health program. Ida Hellender and Howard Waitskin had the lead review of the month. In the monthly review, they conclude by questioning whether single payer is actually enough in the modern time to make things good and just. And I think that the way I look at single payer is it's like to have a Canadian-style Medicare for all is the least increment that would actually begin to make things fair, because it would give the public the power over the care, the basic dignity of care. Hospitals on global budgets and some basic standards for absolutely everybody in the country. That would be the beginning. The very beginning of, it's like the least increment of change that would be acceptable to start to have a system that we would think to be dignified for our patients, and probably not far from enough. Just having access to care doesn't eliminate disparities or in terms of economics and race and rural versus urban and so on. So I think I think that part of our job in PNHP is to say we can do so much better, and this would be the minimum standard. And part of the challenge with the state-based approach is that you begin to fall in. It's very seductive to think that we can make it work here in New York, which has great enthusiasm, but does not solve the problem for the people of Louisiana in any way.
I've been reading this book. This is an Uprising. It's just an amazing book that talks about all these social justice movements that have won victories over the past 50 years, and trying to look at them and seeing what's in common. And it seems like it's both the local organizing as well as a movement is generated, whether it's by the local organizers or not. That brings a whole lot of people out, and people take risks, and as long as they're not violent, it seems like other people attract this. So even though the initial demonstration or whatever may be put down, the next time there's more and more people joining in. So I'm thinking, how can the single-payer movement learn from these successful social justice issues? And you can name 5 or 6 of them right off immediately. But the common denominator is a large number of people were involved and made the powers that be bend to their will, basically. So I'm thinking conceivable that we could organize a whole lot of people that are screwed over the system to show up and get in the streets at, say, the conventions, political conventions outside, and people that are injured by the system.
I think that's already happening, personally, and I'll try to give the evidence for that. I think we should try to define the PNHP place in the planet and the world here, because Physicians for a National Health Program is, first of all, trying to recruit the physicians of this country to the idea with great success, I believe. I think most doctors want a national health program, even though they're not activists, even though they're kind of the so-called silent majority. They reluctantly say sooner or later, we know it has to be this way. And without winning the profession to the idea, or at the very least neutralizing the profession, we know it wouldn't be an easy transition. So I think that our work within our own profession is a special role for PNHP, and why we need to have Physicians for a National Health Program and not just, a mass movement for a national health program.
Canada and Saskatchewan,
yeah,
when this single-payer program was going to be implemented, they say we're going to go on a strike, but the strike was busted. There was a way, and they, eventually resumed their practices.
So if you have a Labor Party, a mass movement, and 15 years of experience of a single-payer system for hospital care, which they all had in Saskatchewan, then you can crush the doctors lickety-split in that context. But in this time, we don't have a Labor Party. We don't have a great example. Maybe we do if we wanted to draw out Medicare further, if we wanted to talk about the successes of the VA. And sad to say, the incredible failure of privatizing the VA, led by the senator in charge of the VA, the candidate for president for the Democratic Party, Bernie Sanders. The privatization of the VA that we just saw that they're saying has failed. No wonder it failed. It was privatization, not more money for the public VA. Anyway, we live in a very different time. So we do have a special role within our profession, but we also have enormous success within our profession of winning people to this idea. So I would just say, you know, Physicians for National Health Program, in my opinion, has a real place. That said, there is an incipient mass movement for single payer. It's not just that Bernie Sanders is for single payer and a good spokesman for it. It's also that there's a mass substrate of millions of people who want someone to be speaking for single payer. There is a consciousness about single payer. There are freaking folk songs about single payer all over the country.
How do we get them out in the streets?
Well, people were out in the streets in the run-up to Obamacare. The trick was that you had a defeat for the working class, clothed in, you had a wolf in sheep's clothing, called Obamacare, where the goal was that everyone was going to have some kind of insurance. The other day on NPR, I heard the new NPR health reporter say that, well, after Obamacare, practically everyone has health insurance. I mean, she said, not me, she said, I mean, 9 out of 10 Americans have health insurance. Wait a minute, that leaves 30 million people out, according to your own glib victory quote, 30 million people, practically everyone. 30 million people is not practically everyone. Hello, practically everyone is like, 1 or 2. We're not talking 30 million people left out, right? And they're saying practically everyone. So the goal of insurance is not the goal that most people want. And I do think that people can be mobilized. The question of whether we're the best people to mobilize them, physicians we're not the best organizers. I think that with the physician's proposal, we should be organizers within our own front yard, just within our own domain. We should say to our friends and colleagues, family members, the people we immediately feel comfortable with, sign on to this, it will make a difference. And we should be organizers in that way. And we should have an email that we can send to, the staff on the hospital that we're comfortable sending to the whole staff on the hospital. Many of us are already known as some kind of radical, but a very reasonable proposal published in a peer-reviewed journal. We'd like you to look at it. We'd like you to consider signing on. That kind of thing. I think that we can do that ourselves. The question that you're asking, David, is whether there'll be a tidal wave. I think that, well, I have a lot of confidence in the class struggle. I don't think that finance capital is the way of the future. It's just not working for many people right now, all over the world. And it seems to me that the most astonishing thing of all about the proposal for single-parent health insurance is that it gets into the mainstream discussion again and again and again. We're supposedly off the table. We're supposedly not in the game. We're supposedly not going to happen. I think Hillary Clinton actually said that. Oh, single payer, never going to happen. I think she said that in the campaign season a few weeks ago. And there is kind of this new phenomenon of the Democratic Party establishment being our most vocal critics right now. The so-called left-leaning economists. I don't know what's left-wing about them. There's actually nothing at all left-wing about these people. They're for the biggest corporations, but they're left-leaning somehow. Saying that single payer was never going to work and so on. And the establishment is telling us to buzz off relentlessly. And yet you turn around and you open their newspapers day after day, and we're right there. The upshot in the New York Times is saying, well, let's take a closer look at Bernie's proposal. And let's think about, Karen Palmer publishes something in the Toronto Star, and it gets this enormous legs where the right wing in Canada writes back, and then they give her platform to respond to them, and it becomes a real dialogue. So what is it about this proposal that keeps it going? Well, first of all, it will work. I mean, that's the biggest thing. And the next thing is that it's been many, many years since there was any concession to the poor. There have been takebacks from the poor just for, going on 3.5 decades. And it's not going to stand. It's not going to continue forever and ever. And I think that within that context, when the people in charge face a crisis, they'll look for ideas that work. And our ability to continue to have thousands of people, millions, hopefully millions of people, well educated about this proposal will win out. And I think there's an example of a mass movement that we could actually point to. Meetings just like the one that you're having now were held all over Spain for quite a few years. There was a mass movement, a rebellion, and it had to do with the education about the privatization of healthcare that had been done in meetings in libraries and churches and union halls over many years. It didn't really have to do with something that happened all of a sudden because of a magical organizing tactic.
Just on a footnote on what Hillary said, John Guyman's latest paper points out that in 1994, when Hillary failed to get it together, made the big effort for health insurance at that time, Hillary said at that time, if there is no health care reform this year, and if for whatever reason the Congress doesn't pass health care reform, I believe that by the year 2000, we will have a single-payer system. I don't even think it's a close call politically. I think that the momentum for a single-payer system will sweep the country. It will be such a huge popular issue that even if it's not successful the first time, it will eventually. 1994, Hillary.
Yeah, I think so. I think that's a problem that they recognize. That Celinda Lake, the famous political advisor, operative, pollster, who did all kinds of work for Obama, trying to figure out a long time ago in that period, I think in the early 1990s, said that they were astonished that the more voters understood single payer, the more popular it got. And I think Hillary's reflecting that research. But of course, there's also the famous dialogue that Hillary had with David Himmelstein, at the White House. They were looking at what kind of reform there should be. And there was a meeting given to single payer, and it was well received. And then the word came down that that was it. We heard from the single payer people, we know what it's all about, and we're not going to do it. If we want to verify this, it's been published relatively recently, in fact. Hillary says to Himmelstein, well, how would you envision single payer happening? And Himmelstein says something like, well, how about the President of the United States leads a popular crusade on behalf of the American people? Hillary says, tell me something interesting. Tell me something real. Is that the quote? The point is that Roseanne DeMoro, the National Nurses United leader, is correct. Sometimes leaders are not made, they're cornered. And Hillary Clinton may turn out to be the best champion of single payer that the country's ever seen. She may turn out to be the Tommy Douglas.
That reminds me of a Franklin Roosevelt quote where it was, whatever it was, Social Security or something like that. He said, I'm favor of what you want to do, but you got to make me do it.
The system in our country is so fractured and undignified. I can't, every day I'm astonished what people put up with. And I don't think it's lost on many people how ridiculous the whole thing is. And money always trumps, always trumps the question.
In the New York Times, at least today, they talked about the Urban Institute, highly critical of Bernie Sanders' bill, and his proposal that it would be much more expensive than he envisions. Any comments about that?
Yeah, so I've been reading the Holohan is the name of the lead author of these things, and I've been looking at this for a long time. These are people funded by our opponents saying that this won't work because it'll cost too much. It'll be too disruptive to the system. It'll cost too much to pay for all the the free care to the uninsured. You know, everybody's going to rush in for their colonoscopy or their herniorrhaphy that they're putting off. I don't think there's much evidence of the assumptions of cost that they have. And the other thing is that the cost assumptions in those studies are based upon a multiplayer system. You know, so the methodology is kind of outrageous. You would just take the assumptions of what everything costs now, add all the uninsured, and just say it would cost that much more, and then sort of take all the taxpayers, divide by that, and say, oh my God, it's the most unbelievable tax increase in history. The other thing that always happens is that they don't take into account all of the out-of-pocket and private spending that individual families do now. So I just think the methodology is crap, if you will. And I know that David and Steffi, because of the Bernie Sanders campaign, answered it in the Huffington Post. I don't know what the right venue to answer these kinds of things is. I do think it's very useful to have it answered right away. It would be great if there was some kind of a forum to dissect these things. You know, there are really unbelievable scoundrels and charlatans in health policy. In Vermont, one of the ones that came up, I think, a few times was Ken Thorpe, who's the eminent health policy scholar from, I want to say Duke, but somewhere down south, from Emory. And his idea was, you know, chronic disease management. And his idea continues to get a lot of play, even though in the health policy literature, it's utterly discredited as a way to save money. You know, it might be a good idea to give more resources to people with serious chronic disease, but boasting that it saves society a lot of money is just crap. It's not true. And, you know, I think that there's a little bit of the health policy discussions that we should be confident about. You know, for example, the skin in the game discussion is one where I think we should be taking the enemy on their strengths. You know, it makes sense to everybody that well, you know, everybody should pay something. Well, of course, everybody should pay something, but paying something at the point of delivery of care, a user fee, paying a copay, a deductible, or a procedure fee at the time of getting it has been very well shown to discourage people from getting necessary care. The science shows that it's a bad idea if you want people to get necessary care, if you want people to get the care they actually need. Charging them when they get it doesn't work. And you can look across the planet, you can look at very poor people, you can look at wealthy people, you can look at drugs that people need. People who have had serious health events and then need care afterward, you know, myocardial infarction and then big vascular events, people that have diabetes, kids who have asthma. You look at these studies and it just shows you that you should not charge people when they need the care. They should freaking get it. And that's science. That's not even, you know, I'm annoyed that society would so disobey the policy science, and yet you have an official ideology that people need to go shopping somehow. Right when you had your brain tumor or your aneurysm or your heart attack, you're supposed to go shopping. It's ludicrous on the face of it, and it's against every article you can find that would support it. And I think that there's a lot of popular education that we can have a lot of good fun with, and also maybe make a big difference with.
The New York Times is a reasonably respected newspaper, and today, as I mentioned, actually they mentioned Kenneth Thorpe as well as the Urban Institute. Interesting you said that because I forgot about that. And how does one sort of contradict what they say? I mean, this isn't the Seattle Times; it's the New York Times, and I don't know. I mean, how it was a big splash as far as I can see.
Well, I think Adam Gaffney tried to respond to the what's her name, Margaret Katzinger upshot. I think that the reality is the Urban Institute it's funded by the industries, and it's going to be the bottom line, I think, in my opinion. But how to say that and where to say that gets increasingly challenging, right? Maybe we need to think about writing a peer-reviewed kind of article. Do you remember the All-Hat study? All-Hat was a study of antihypertensives done by the VA. They looked at the old drugs that were generic, and they compared them to some of the new ones that weren't. And, lo and behold, they found that drugs that had worked for millions of people would continue to work for millions of people. And the pharmaceutical industry spent over a decade trying to discredit this one study because there was no market share in hydrochlorothiazide, spironolactone, and so on. The author that took them down published in the New England Journal the story of how there was this huge effort to discredit this study. I think we find ourselves in a similar position where we need to fight for our ground in science terms too. That's why I was kind of saying that, answering in the Huffington Post is good, but we might want to think about really dissecting their methods in other venues as well if we have the energy.
Thank you, Andy. Thank you so much.
Thank you.
Bye-bye.
And we'll be in touch. Thanks again, Andy.
All right, very good.
Bye-bye.